Good morning. Thank you everyone for being here today. I'm Colleen Carr. I serve as the Director of the Secretariat for the National Action Alliance for Suicide Prevention. And we're delighted to be here today with a number of our partners and in collaboration with the Department of Veterans Affairs on this important and very timely event. A little bit about the Action Alliance for those of you who are not familiar with us. We were launched in 2010 as the nation's public-private partnership for suicide prevention. We bring together senior leaders from the federal government, major federal agencies like Department of Defense and VA and Health and Human Services and a variety of others with the private sector. Senior leaders from various sectors like the railroad, entertainment, healthcare, social media, construction, et cetera. And it's really to create a space for the nation to come together and really align our suicide prevention efforts so we can have greater impact and advance the national strategy for suicide prevention. And one of the first things we did as an alliance was revise the national strategy and release that in 2012 in collaboration with the U.S. Surgeon General's office. And in that national strategy, there was a goal, Goal 4, which was about really emphasizing the role of media in suicide prevention. And Goal 4 talks about promoting responsible media reporting of suicide, accurate portrayals of suicide and mental illnesses in the entertainment industry, and the safety of online content related to suicide. And that's really what brings us here today. To advance Goal 4, the Action Alliance has been working over the last 8 years with a number of the partners in the room today to change the conversation about suicide nationally and making sure we're shifting that narrative of stories of death and tragedy and despair to stories of hope and resiliency and survival. And that is part of our work with news media, it's part of our work with the entertainment industry, and part of our work with everyone who's messaging about suicide, which is many of you in the room here today. Since that time, we've had a number of efforts. We've collaborated with the Pointer Institute and SAVE and EDC on an online training. We've done training with journalists across the country. And we've held a series of media panels like the one we're having today. So we look forward to today's event and continuing to collaborate in this space and with news media on this important topic going forward. What we're going to do today is hear from a number of our experts that are on the panel, and then we're really going to open it up and have a dialogue. We want to answer the questions that you've come here today with, and I know we have a number of people joining us on live stream as well, so I think we'll have a really engaging conversation, and it'll be a very interactive event. With that, given the recent coverage of deaths about suicide and veterans on campuses, we thought this event would be very timely and appropriate and a good time to have this dialogue because news media is covering suicide more and more, and we want to make sure this is a collaboration where we're working together on this important topic. So with that, I couldn't be more delighted to introduce our panelists today. They're going to each introduce themselves and tell you a little bit more about their expertise and their work in this space. So I will start with Dr. Keita Franklin.
Thank you. Good morning, everyone. I am Dr. Keita Franklin. I'm the Executive Director of Suicide Prevention for the Department of Veteran Affairs, and I appreciate everybody coming to this important event this morning and am very grateful to our partners, the Tragedy Assistance Program, SAVE, the National Action Alliance, and their leadership, and also Leo Shane for his good work on reporting on safe messaging and suicide. And as we get started today, this morning, I'm just eager to talk with people about how we can better talk about messages of hope when it comes to veteran issues, not just about suicide, but veteran issues across the board. And I'm pleased to have some time this afternoon or this morning with our veteran service organizations that play a critical role in the lives of our veterans. And so I'm happy to see so many of you in the room this morning. And I'm looking forward to more discussion about the role of media and partnership in our work with veterans.
Thank you, Dr. Franklin. My name is Jerry Reed. I'm the Senior Vice President for Practice Leadership at the Education Development Center. And we, in practice leadership, focus on 4 primary areas at EDC. The lead area for us, at least in the practice leadership space, is suicide prevention. So you may know us by other names such as the Suicide Prevention Resource Center, the Action Alliance for Suicide Prevention, the Injury Control Research Center for Suicide Prevention, and also other programs that we operate in the suicide prevention space. I've been in the field for about 25 years. I had the privilege of leading the task force that wrote the National Strategy for Suicide Prevention with the Surgeon General, and was delighted to see that with people like Dr. Reidenberg and others, we were able to really make the foundation of this document that everybody has a role in suicide prevention. It's not just the heroic clinician. It's not just the loved one of someone who's struggling with suicide, but it's all of us. And we tried really hard to craft and construct objectives that really spoke to what a faith community could do, what a state government could do, what the media could do. And that's, again, rationale for why we've gathered today, to try to make that point. I am a veteran myself, so it's a personal spot in my heart to make sure we get this right for those who struggle. And I've served as a Department of the Army civilian for about 16 years, working with men and women who serve overseas for the U.S. Army. So I'm delighted to be here. I hope we can help answer some critical questions. And I would just end with a belief that I think we all hold dearly. Suicide in many cases is preventable, not inevitable, and anything we can do to prevent that suicide is time well spent. Thank you.
Thank you, Dr. Reed, and thank you for your service, and Dr. Franklin for your service, and thank you, Colleen, and the Action Alliance for coordinating this for the media today and for all of those that are participating. My name is Dr. Dan Reidenberg. I'm the Executive Director of SAVE, Suicide Awareness Voices of Education. We're a national nonprofit organization working to prevent suicide, and our area of specialty, and mine in particular, is around working with media and the entertainment industry. I led the development and wrote the best practices for media reporting on suicide. I was honored to serve under Jerry in the development of the national strategy that he mentioned, and specifically, I was the lead for the section that wrote the particular areas around media reporting on suicide, entertainment industry being involved, and issuing the national award for media reporting on suicide. I've spent a number of years training journalists throughout this country and, in fact, around the world for the World Health Organization. I've worked in partnership with the Poynter Institute training journalists. And for me, the additional piece that I bring to this is a clinical background as a psychologist and working with patients and families. For me, what I'm really excited about is the opportunity to share with media how we can move from this concept that we would be trying to restrict actual media from reporting on suicide to responsible reporting on suicide, because there is, in fact, a way in which media can report on suicide, that we actually want people to report more on suicide, and doing so safely can actually turn things around and, in fact, prevent contagion. So that's really my hope today, and we can hopefully address some of those questions for you today.
Thank you. Good morning. It's really an honor to be here, and thank you for having me on the panel. My name is Kim Ruwako. I am Vice President of Suicide Postvention and Prevention for the Tragedy Assistance Program for Survivors, or TAPS. It's a 501c3. We provide comprehensive peer-based support for all those who are grieving a death in the military, and we've particularly built a program called Postvention around all those who have lost a loved one who served to suicide. I'm also a suicide loss survivor myself. My husband was a Marine Corps helicopter pilot. After 2 combat tours, he came back and died by suicide in 2005. So I'm here really today to talk to you about the impact of suicide, postvention, and how the media can really, really help with us finding hope and healing for this population and decreasing risk. We know that after a suicide, those that are impacted, which in research will tell us is about 135 people, those that are impacted are at increased risk for suicide, for mental health issues, for addiction, for reclusiveness, and other issues. They are a very vulnerable population. Very often after a suicide, we think about, well, how did this happen? Why did this person die? But we're not thinking about the ripple effect of the impact of those who have been exposed to the suicide, are grieving the suicide, and have some, guilt and shame around the loss. So I'm hoping we can join with the media to really look at this population, to really understand the best practices in postvention and how you can incorporate in this story so that we can prevent future suicides by having good postvention and good stories about those left behind. So thank you for having me here this morning.
Yeah, hi. So these are subject matter experts, and I'm the media part of the media panel here. So Leo Shane with Deputy Editor over at Military Times. I've been covering military and veterans issues for the last 15 years, and unfortunately that has meant quite a few stories about veterans and military suicide over the years. I don't know that I'm an expert here, but I am someone who has had to write a lot of these stories and figured out some things that work, some things that don't work, learn some lessons about some insensitivities that can be there. So. And really, there is a desire from me and my peers to write about this responsibly. It doesn't mean we always get to it, but we don't want to be part of the problem. We want to be shining light on problems and helping solve them. So, so happy to be here. Happy to chat about my experiences, but also looking forward to what you all have to say on this.
Great. Well, thank you. As you can see, we have a very diverse panel here today with a number of different perspectives and experiences and subject matter expertise. So with that, we are going to open up the room to those that might have questions. So feel free to stand up if you do have a question for the panel.
I'm Jennifer Thurston, and I was a active duty casualty assistance officer in the state of California for 2 years. And of the 20, I didn't keep track of those that I notified, but of the 20 I served, those families, 9 of those loved ones had taken their life between the ages of 19 and 32. And some of this came from, they were all actually either returning from active duty into a Guard or Reserve unit or in the Guard or Reserve. And I think that there's a real deficiency there of resources when service members are deployed into a combat situation and then return home to a community that doesn't understand them and they can't relate to or feel like they fit in. So I'm wondering on a couple of notes, and one is when we're refrad, we go through, psychological training, physical training. Currently, is there anything in place for the families to go through so that they can better understand their veteran when they come home, and even resources for the community? Also, my home of record is in California. I'm currently working with Vietnam Veterans of America. We have the Voice Awards at Paramount, and I don't know if you're aware. It's a wonderful, and it brings awareness to suicide and mental illness disabilities, and pays tribute to those shows and movies that actually shed light on this, and in a not negative way. And then finally, I don't know if any of you know Steve Dunning. I'm thinking maybe, Dan, you do. Steve Dunning. So I used to work for the Office of the Chief of Public Affairs, OCPA. I'm one of 3 that was in that office. And so Steve at one time was the liaison between the Hollywood studios and the military. And we brought Medal of Honor recipients to the red carpets, and I was working with him to bring Gold Star families as well. Before he left and I deployed to Guantanamo, we had talked about our soldier homes. And so we have from World War II all the way up Vietnam, adopting a unit, specifically Guard and Reserve units, because these service members have so many amazing stories. And I just feel like if they could come into a Guard or Reserve unit once a quarter and just be there amongst the younger generation, it's the best suicide prevention, in my opinion, because these are our heroes and we admire them. And we don't hear enough, so they really want someone to talk to often. and we often don't know their story. So thank you for listening.
Great. Thank you. And Dr. Franklin, I'll turn that first question to you about family supports.
Yes, thank you so much. And it is such a good dialogue, and you shared a lot of good critical information that, and I would provide some framing context for the rest of the group so people know. The reserve, she's absolutely right. The Reserve and Guard are a unique population group that are at distinct risk. And when we study the data, you hear a lot in the media, perhaps about 20 veterans a day that end their life by suicide. About 3.4 of the 20 fall in this group of never federally activated former Reserve and Guard. So it is a significant amount that is a unique group that we can and should be providing additional resources towards. In the past year, inside the VA, we have developed a closer relationship with the National Guard and the Reserve component in such a way that our leadership has signed an official agreement with them to bring our vet centers. We have mobile vet centers. If anybody has ever seen one, it's a pretty neat capability, but we have them out on the road to drill weekends to try to start developing relationships early with the Reserve and Guard component. And then we've also reached out to one of the VSOs that is uniquely positioned to engage on advocacy issues and reaching out to their population that focus on Reserve and Guard as well. So we made a little bit of traction, but certainly more work to go, and I appreciate you highlighting that unique subpopulation group, because that is how we're going to chip away at this issue, is by identifying the subpopulation groups and chasing it down. I would love for you to also hear from Kim Morocco, just because she has a wealth of knowledge on the family side of the house that might add some more depth to this.
Great, thank you for bringing up those points, and thank you for your service, because casualty assistance officers are in a very critical position with families to notify them about the deaths, and I appreciate how difficult that was, so thank you for that. The Guard units are difficult. It's a difficult job for families, too, because we have the soldier themselves are have 1 foot in the military and 1 foot in the civilian world, right? Like during the week, very often they're in civilian jobs, and then they also have this military component. And sometimes that makes it more difficult for families to really know what the resources are for them, because they're a little less connected to the active duty the way that the regular active duties are. So as far as the media's role in that and how they can help, having stories not about the fact that resources are difficult and unavailable for these families, but really highlighting what resources are available, and then stories of hope of people who have gotten those resources, used them, and gotten better, would really shift the way that families feel hopeful that they can help their own service member, and really give them a knowledge about what's out there. Because the challenges for families very often is to understand, okay, what am I seeing, right? Okay, what is this normal, or is this part of deployment, or is this mental health, or is this suicide risk? So they need to know what are they seeing. They need to know what to do with what they're seeing, and they need to know what's going to happen when they go and get that help. So highlighting that and showing examples of that with family members, with service members who have understood what they're seeing, gotten help, and used that resource really is an invaluable way to help our families going forward.
And I would just offer, as the proud father-in-law of a National Guardsman, we talk about this all the time. I think we have to work with people like Captain Matt Kleiman over at the Guard Bureau, who really is committed to trying to make sure the Guard and the Reserve components are as informed as they can be in respect of the environment that they operate in, but at the same time be mindful that there is a National Suicide Prevention Resource Center that has an infrastructure in every state across the nation. So these family members and these Guardsmen who live in their home communities, if they need suicide prevention services when the Guard isn't maybe congregating on the weekend or in a reserve capacity, there's resources in almost every one of these communities that could be tapped into for someone who struggles serving in the Guard or Reserve.
I'll just add on to that. Some of the service members aren't reaching out for reasons that we are aware, because they're told they'll lose their clearance, they'll lose their position. Some of them, flew, and so that is at the heart of some of this, not all.
Fair point.
Yep. That's a reality. I think the one piece I would bring into it relative to the media is that we don't do well training the media on how to do these conversations, how to have these interviews with those people who have served or are still serving and their families so that they can tell the story right. And it's an important balancing act. We have to tell the story that they lived through and the story that the families are experiencing, as well as that story of hope and recovery and the story that they did survive and they can get through. But we don't train media how to do that very effectively and give them the kinds of questions to ask. If we did that, we would elicit some of those responses from those that are serving that takes away some of that stigma. Exactly.
I think that just the unit commanders aren't aware
Right.
that when we have drill weekend, we have the training, the mandatory training, and the commanders are just trying to get through it without providing the actual resources.
Correct.
Mr. Shane, and then
Go ahead.
Go ahead.
Good. I just wanted to add one little thing, just because very often media will reach out to survivors, or families that fall under Gold Star families, or veterans even, to tell stories. And I would advise that you go through one of us to help you find survivors that are ready to tell their story. Very often in the beginning, when they're newer and they're still grieving, especially with suicide, they'll first of all say, "I never saw it coming." 2 years later or so, on the look back, they'll have a different story. So really understanding when is a good time to reach out to survivors, reaching out to organizations like TAPS or SAVE to find people that are ready to tell their story is really important. Go ahead.
And just to build off the media side, because I think you said a lot of times these communities don't understand the guardsmen, the reservists coming back, and some of those issues. I mean, look, we're at a time of media consolidation. There's a lot of local papers that might have used to have a military-focused reporter, even a veterans-focused reporter, who don't have that anymore. So a lot of the folks you're going to be dealing with, this may be the first time they've ever written on suicide. I'll write about the suicide issue probably 24 times this year. This may be the only time they write about it in 2 years. There may be something that came up. So there is going to be a lot more education that you have to work on. There's going to be some more patience that you have to work on. But it does speak to the importance of outreach ahead of time, that folks know. If I'm throwing an education story today, I don't know what the heck I'm supposed to do with it. I've got to go. I've got to call some people I know. I got to figure out those resources. I don't know necessarily what I'm looking for. So if you're worried that they're not going to be highlighting the right resources, if they don't know where to call, if they don't know where to find those numbers, if they don't know what to highlight, they're going to have trouble with that.
Hi, I'm Ritu Chatterjee. I cover mental health for National Public Radio. So when you talk about positive stories, I'm sure there are tons of individual stories out there, but I'm wondering if there are pockets that have made really good progress in getting people who are at risk of suicide help, whether it's among veterans or anywhere else.
I think there are positive stories out there, and there are places. There are different units that have really taken this on and made it a focus. Not every particular unit, when they come in for their drill training, for example, that we hear with the Guard, not everybody prior to deployment or after, but there are some that really have decided to take a step and say, we will actually address this. We will talk about it before and after. And they follow that up after somebody's returned. So I think that there are some places that are seeing some of those real active, engaged conversations happening. I think the stigma is still the biggest challenge that we have. And until we figure out how to change that conversation, that they can disclose this, then we're going to be better off.
So when you talk about conversations, what kind of conversations? And what about just making sure they get access to help when they need it?
So for people to get access to help, they have to be willing to accept that this is a real problem for them first, and they've got to be willing to accept that there is a place that they can go without fear of losing their clearance or losing their rank, or fear that the rest of their unit isn't going to want to be deployed with them or going to be active with them. So we need to first break through the stigma to be able to raise awareness, and then to educate, then to get them to the access to care. Whether that is right in military barracks where they need it, where maybe it's out on deployment that they need it, But we need to make sure that as Dr. Reed was saying, that everyone has a part in this. It's not just sending them to a medical professional, that it is other people right within their unit that they can talk to, that they can get that support from. We need to also make sure that families are informed and educated about this. And again, some places I think are doing this better to encourage that person who's serving or has served, that they will reach out for that help. There are places for access, whether it's the VA system, in or out of the system, that people can go to, but we've got to break through that first part to get them to the place that says, I can do this, and then they can have those success stories. They can hear that there are treatments that work. Whether you're talking about the CAMS approach, the collaborative approach, or DBT or CBT, cognitive behavioral therapy or dialectic and behavior therapy, there are different approaches that we need to get them to. We just got to get them, break that through that first part.
I would say too, like June 11th, there's going to be a suicide prevention rally on the Hill. We have a speaker there. And Dan can give a little bit more details about that, but one of the speakers there is a soldier who's with the Guard, who's going to talk about struggling with mental health issues, having an attempt by suicide, and then being able to recover and still maintain his job and his clearance and his role and his respect of his fellow soldiers. These are the kinds of stories that are really critical, because in the military, role models, hearing from somebody else how they navigated that, how they were able to maintain their career, and how that's kind of impacted their family is a critical part of this, because there's so many people. You hear the bad stories about losing your clearance or not being able to stay in the military, but there's equally as many, if not more, people who have recovered and really maintained their clearances and they've been promoted. And so we need to hear more stories about that. We need to have coverage about that, and get more role models that are really talking about that.
I would just want to add, to answer your question directly, I think the Veterans Crisis Line is a perfect example of where a veteran or a spouse of a veteran or someone who cares for a veteran can call 1-800-273-TALK and instantly connect with somebody who's well-versed in veteran issues, well-versed in the veterans infrastructure, and can get that veteran and his or her loved one into care. And there are stories, really good stories, where rescues have been made. I've been in the room when an appointment has been made for a veteran calling from Arkansas with the VA hospital in Arkansas, so they don't have to wait and walk in cold. But it's already pre-set up, so they can walk right in, they're expected, and they can get care. So there's a lot of those stories out there. I think there's a wonderful Make the Connection campaign that you may have seen about, where veterans of different conflicts from different areas talk about their own mental health story, encouraging veterans from those same conflicts to share their story and to have the courage to step forward and get the help they deserve. And so they're there. I just don't think they're in our mind's eye as often. I mean, we talk about the 20 per day who die by suicide. We don't talk about the thousands who live. And we have to do that because there are many who come back. And I worry most about an image that we leave the public that veterans are broken. And veterans are not broken. They're very proud contributors of society, and we need to tell these stories. They've gone through a horrific experience in many cases, but many are so resilient, come back, do the job, and that story needs to be told as well for other veterans who may be struggling, who seek the wisdom and the courage to step forward themselves.
There's also a lot of social media that people can engage with. The Be There campaign is a really good example of that, where veterans and their families can actually participate in having the conversations and, again, breaking down that stigma to make it okay for them to reach out for help to any of the veterans kinds of services that are available. So social media also plays an important role in this.
Marie, I think. Ben, go ahead.
Hi, Ben Kessling with the Wall Street Journal. How much are resources being misplaced with VA outreach? And I mean, most recently had on the Hill, there was a problem with the VA not spending the money on like advertising and whatnot that was allocated to it. How much is that? I mean, how much is that throwing money at the wrong part of the problem? How much of highlighting the call center is not? I mean, no matter how much you highlight it and make sure that the word's out there on the call center, how many folks are not going to call in, and you need to find alternative ways of making these connections, right? Like, why call a random number where you talk to a random person who may not be a veteran? that you have very little trust in, how much do you need to build these organic pathways for this stuff, and like what is the current roadblock to building those organic pathways?
I can go ahead and start us on that one, but I would love for you to hear from my colleagues on this as well, because I take a little bit of issue with the first part of the phrasing of the question in terms of resources being misplaced, because there has not been misplaced resources, so I would sort of reframe the question. But one thing we know about outreach is that it should be targeted, and it needs to be targeted to those populations that are most at risk. And so you may have heard some swirl in the media or on the Hill about VA outreach and resources and things like that, but know that there are purposeful and strategic decisions at play that involve studying at-risk groups and doing very targeted outreach. It's a scientific process. It's not just done sort of a willy-nilly across the board. So I could give you countless examples, but our outreach at the VA is targeted towards veterans that are struggling in rural areas, towards female veterans, towards veterans that are ages 18 to 34 that we know have an increased risk, towards veterans over the age of 55, because that is a significant amount of our data tells us where to do the outreach. But again, I would love for you to hear from my colleagues. I don't know how they're going to answer this, but good question so that we can see more in terms of how we're doing this and what the industry experts think as well.
Colleen, if I could, 20 years ago when I worked on the Hill, we were looking at suicide as a national public health problem, and there was basically no response in the general public or in the military or in the Veterans Administration. That's changed dramatically in the last 20 years. And I think that one of the things we have to be very mindful of, and Dr. Franklin and I talk about this all the time, if 20 veterans a day are dying by suicide and 6 are touching the Veterans Health Administration and 14 are not, we have to find more effective ways to partner with one another so we find the veteran where he or she is. And if it means walking through a community mental health center door and we've got the cultural competence to serve them, to recognize where they can best be served and make that referral, then we should do it. And we shouldn't create an image that there's only one door a veteran can walk through. That's going to be the right door. The VSOs in the room, the community mental health services, the hospitals, and at the Education Development Center, we work with those communities, and therefore we work with Dr. Franklin and the Veterans Administration to try to make sure whatever door the veteran wants to walk through, he or she knows they're going to get the help they deserve. And I think we have to just be mindful that it's only been 20 years that this problem has really been before us, and there's been an awful lot of progress, not enough, and we have to really, I think to your question, Ben, I think we really have to work more and more together using a public health approach to see where the veterans at risk are and then direct resources wherever they come from to those populations so we can be much more successful at finding them.
I would add, too, that when we think about the crisis line, we're not thinking about it, in my mind, from a silo perspective. For example, we have a partnership with the VA and with the crisis line. So whenever a call comes, we give the crisis line to all our survivors, military survivors, all who are at risk, right? They may call into that crisis line. If they're just grieving, there's an assessment of whether they're having suicide issues or is it grief issues. If it's grief issues, we have a warm connection with them. They pull TAPS in, they talk about it, and then TAPS starts talking to them. The same way is true is if our call center, that we have a 24/7 call center answered by peer supporters, if we get a call from a survivor and they are wrestling with suicide and they're in crisis, we have a warm way of calling the crisis line, and they may take over that call. The same way that the crisis line finds resources for our family members in their own communities. So they're reaching back out, pulling in partners to help. So it's not just the crisis line, one call, hang up. They are actually connecting with partners all over the country and pulling in more support. So I think it actually is a nice partnership. And I've seen this change over the last decade that I've been doing this work, where the VA used to be more siloed, but now there's a real intentional focus on collaboration and partners, because they can't do this alone. It's too big of a job. So all of us MSOs and VSOs are working much more closely and much more collaboratively with the VA, and they're not standing alone trying to hold it just at the crisis line.
we have a broken system completely here. When we look at the suicide rates are continue to increase. The CDC has put out reports that there's been a 30% increase since 1999 until 2016. For the public and for everybody, we have serious problems. So whether how Congress allocates dollars or how the VA or DoD allocates dollars, I think is up for question and debate, and that's really where I think the media comes in, is to be able to question some of those things, to try to help really frame what things should be. I think one of the roadblocks, as you had mentioned, however, happens to also be the media. Historically, the media has chosen not to report on suicide. The belief has been if you only report on it if it's a public official or it happens in a public place or it's a well-known celebrity. And that has created a lot of myths and misperceptions for the public and lack of understanding about the topic, as Dr. Reed was talking about in terms of this public health idea that suicide really is involved with. I think that if we can continue to work with the media to better understand what this topic is and how to report on it and where to go and ask some of those really important questions, we are going to start moving the needle forward. So between the news media and between Hollywood, the entertainment industry that puts out messages about these topics, I really believe that has a great potential to help change the conversation. But we can't ignore that either. There's a reality that there's been a change in whether media covers this or not, and how they cover it now is changing. So if we can work together, we can see some good progress.
Quick follow-on. They said there's no one door for to come through into the system, but there is, like, just technically speaking, one door, which is like SEPs and TAPs, right? When somebody leaves active duty, separates from service, there is, in theory, one door by which they can access some of this stuff. And the last time SEPs and TAPs was really overhauled was about probably 6-7 years ago under the Obama administration. Is overhauling SEPs, a re-overhaul of SEPs and TAPs, and the way that people, or whatever each branch calls it, when you leave the service, the way that you get your claims processed, you sign up for the VA system, you get this information. Is there a need for an overhaul of this? And we've seen that it can be done with simple executive order and push through that way. Is that something that this administration needs to do to redo the way that that service members leave the service? And I'd be interested in hearing from everybody up here, including folks who are part of the department.
Why don't we start with Dr. Franklin and we can hear from you.
It's a good question. I don't know if it's in need of an overhaul. I'm not the duty expert on the TAPS program. A little bit I can share with you about it. It involves an executive order that was pushed out about 1.5 years ago that gets after making sure we improve our care during the first 12 months after the service members leave the military. You might be familiar with that executive order. There's 16 lines of work associated with it, and one of the lines of effort does involve making sure that their health care is wrapped up in an easier way so that service members aren't leaving the military and then starting cold with a blank sheet of paper when they apply for health care. And absolutely a shame. And so there's now something called facilitated, this is just in the last year, facilitated enrollment, which involves a set classroom instruction during the transition process where service members have their data pushed into a system that they sign onto, and they're all but registered as they leave. So that it's a streamlined process. So that's new. And then also we've tended in that, as part of that executive order, to their social aspects of leaving, because I think that's part of also what you're getting after too. Are they prepared? Are they socially prepared for their new identity and their new mission in life? And so we've really leveraged the VSOs to develop a new curriculum. And that curriculum has been deployed, again, this is all new, only within the last few months, to make sure that they are able to join a community and a group, and that they know about their new purpose and mission, and that they're tending to their social aspects of no longer wearing the uniform. I could give you other examples, but I want you to hear from the panel too. So,
First of all, we distinguish between TAPS and my TAPS.
yes.
It always, that's what you're talking about, a transition assistance program, also called TAPS. And we know this is a high-risk time for service members. Transitions of any kind are increased risk for suicide and other issues, but particularly in the military, this is a difficult time. So we have seen some changes, since Dr. Franklin's been in DISPO and VA, and really that transition time, focusing more on that, extending the time that they can get health care and mental health care, and the records going back and forth and easier. So we made a lot of progress, I think, in shifting, looking at those people and how we can help them. Also, VSOs and MSOs have now come in partnership with the VA in that, so that they're not handling these people alone. When they're coming into the community, everybody's got to know military culture, what is particularly needed with that culture, how do we access them, how do we care for them, and what are their special needs. There's tons of trainings around that through many of us, including TAPS, on how do you support military families, how are they different than other families, and these kinds of initiatives I think have all come together to support the VA and active duty, the DoD, in the transition time. But there's definitely more work to be done in that area.
And I would just offer that I haven't separated since 1978, so it was a long, long time ago. But I would say that when I was early in my career, I was at Fort Myer, Virginia, and we ran a program called the Army Career Alumni Program, which was a really outstanding initiative that, as Kim said, transitions are tough for anybody, from high school to college, from college to work, from work to retirement, from military to non-military. That's a very at-risk time for people who are not prepared. And that would include someone leaving the military to return to either university or back home or whatever. So what I loved about the Army Career Alumni Program, and I don't think it's operational in the same way, was it engaged family members, it had an employment component, it had an educational component, and it had a social service component. So every need that you or your family might be able to identify prior to discharge, you were pretty ready to walk out the gate and re-enter your community well prepared. I don't know if it's that detailed anymore. It was a pilot program at the time, but it sure helped a lot of service members leave ready to re-engage and, frankly, become ambassadors for the military because they were taken care of so well. As they left the service, they spoke highly about it when they got home.
Mr. Shane, I'm wondering if I can.
Well, first off, I don't really want to help Ben because I want to work against him on that story and get that story before him. But to speak to that issue, there was conversation before about the idea of positive stories the media can do and how to do this, and there's going to be some bristling from many reporters that we're trying to put a positive spin on this. But I see that kind of topic, and Ben, there's probably only a handful of people in the country who would even look into that right now. But this is clearly something that is a helpful conversation to have. This is an important conversation to have that is not, trying to put a positive spin on the suicide issue, but is looking at what are the problems, what is being addressed here, how are those 14 out of the 20 that aren't connected going to be connected. So, when you're thinking of, ways to do this, I don't want to quibble too much with positive, but I would think more along the lines of what are advocacy, what are things that you could do, what are ways that you could pull in a reporter to do a story that is going to point at something that's going to try and solve the problem rather than just report on the problem again, rather than just say the 20 a day. What's the way to address that issue? So, and give it to me before Ben.
And then just to follow on to that, some of the things that we've heard so far, transitions, healthcare, both in the VHA and outside in the community health system and family supports. And from a reporter perspective, what are ways that you cover these diverse topics in suicide in a way that still resonates with your readers? What have you learned kind of in that journey?
Yeah, I think look, there's a lot of divide right now between people who understand the military and people who don't in society, and that's with the all volunteer military. We've self-selected down to a smaller group of people. I never served. There's been quite an education for me just understanding the terminology, some of the culture, some of those things. I've also found that the veterans groups and most veterans are more than happy to talk about these things, more than happy to talk about those issues, and that lots of readers outside of the military community love to read these things too. People don't like being disconnected. It's just a matter of trying to understand. So the important thing is, how do you responsibly do that? How do you find ways to introduce this? I've said to folks for years, I don't understand why most major metropolitan newspapers don't have a veterans and military reporter, even if they don't have a big military base, because you've got veterans in your community. You've got these great stories sitting there. I understand the economics of it and the economics of journalism and why we don't have a lot of that. But I think a lot of times, reporters like to tell stories that people are going to be interested in. Reporters like to tell stories that people haven't told before. So, I think part of the pitch for all of you is going to be how do I entice that reporter to take on this issue and take on some. And I think you'll find that most reporters are interested if they can. Finding an angle is not that hard. It's what's a compelling story, what's something that people aren't talking about, and frankly, not as many people are talking about these issues.
And I would add to that families today are more willing to talk. Families are willing to come out with their stories, and they're willing to reach out to media. So it is about this partnership of how can we pair those families that have a story to tell with media that are interested in the topic, that can push an issue that needs to really be discussed.
Thank you. It's a great panel. And thank you, Leo. You're exactly right. People are, if it's not compelling, people aren't going to write it, and people aren't going to read it. We won't learn. Just briefly, can the panel go through some of the common issues or common mistakes that reporters, journalists, or typists make when covering issues around suicide and suicidal ideations?
Sure. Some of the common ones are normalization. They make it seem that this happens to everyone in the exact same way. We heard a little bit about that from Kim. Some of it is around sensationalizing, glorifying either the topic of suicide or suicidal ideation. Sometimes it is about the details in which they describe a particular person when it's only focused on one particular person. From a standpoint of readers and those who are at risk, those who are particularly vulnerable, they over-identify with all of those details in the story, and that increases risk of contagion. So we see these kinds of things most frequently: the normalization that's sensationalizing, the glorifying or focusing on one particular person. We also see things where data and numbers are given out in ways that people don't understand. The public doesn't understand. It becomes very confusing, and that isn't very helpful. Sometimes suicide is still talked about in a way that isn't helpful in terms of understanding the public health approach to this. But probably the biggest mistake that's made is that it's focused solely on the person who's suicidal or has died by suicide. And there's no story of hope. There's no story around recovery or that treatment works. There's in the media industry, it's fairly well known. There's something called the Werther effect, where that is the negative reporting on suicide versus what's called the Papageno effect, which is coping, stories of recovery or mastery over a skill or a deficit. When people come together to support, when those things are added to any story, even if it is about a tragedy that happens, we see reductions in suicides. So those would be the big things that tend to happen.
And then I just might add a piece about the veteran angle, because Dan is the expert on this space, and unless you would prefer to add it, Kim, because I know you know it as well as I do.
Go ahead.
Okay, either way. Okay, either way. Headlines. I think that there's a problem when we see classic headlines about a veteran, and the classic storyline is veteran deployment, PTSD, suicide in some way, shape, or form on a headline, and that's not the case. More of our veteran suicides are around people that haven't deployed than people that have deployed, and PTSD is not always a factor, but the overgeneralization on that is a concern, as well as pictures. I will see a headline of a veteran holding his or her head down in front of a graveyard. It's just what not to do when you're talking about veteran suicide. I mean, the pictures in the background I have seen in very rich descriptions of horrific acts that I think are not necessary, and the safe reporting guidelines would tell you that that's also not a good idea. I don't know what else you would add.
I have a couple things. I mean, I worry about the people that are left behind because they're at increased risk, right? And they're reading these articles. And veterans who are at risk, or anybody who has already thinking a little bit about suicide or struggling at all, when they read this, you can either decrease risk for them or you could increase risk for them. I think where we make mistakes is when we boil suicide down to one or two things, right? Suicide is a very complex, multi-factored event. It's very difficult. Every person has a different path there. So when we have a headline that connects the suicide to one thing, for example, if they say, had a relationship breakup and then he killed himself, you have that spouse who's thinking, oh my gosh, it was my fault, now it's in the press. There was a particular story about suicide in veteran parking lots, and that the headline was something about experts say that they were killing themselves in that location because of the VA's bad care. Well, this is a headline that can now increase risk for all of those people who touch that veteran, the clinician treating them, the support within that VA hospital, and we're making a huge assumption here. People die in different locations for different reasons. They die by suicide for different, multiple reasons. So boiling it down to one reason, one issue, trying to make assumptions about why they died in a certain place is really dangerous and really increases risk for all those who have touched that person who have died in that spot. I also, language. Survivors of suicide loss really don't like the word commit suicide. It implies that the person had a state of mind where they were making a very conscious decision. Commit is associated with bad things. So it's like they're doing a crime, whether you commit a crime or commit adultery. So died by suicide, but people who die by suicide are often very, very sick with multiple other stressors happening in their life. So keep in mind that the people that are going to be reading this and that are impacted by that suicide, and is this going to be helpful for them, or is it going to be harmful? You have the ability here to make that choice by talking about it being multiple factored.
Can I just add one other quick thing? The word epidemic is a major error and mistake that is very commonly used, whether it's around veteran or active duty military service and suicide. It is commonly put in all media reports. But it's really easy to clarify that there is no epidemic of suicide. There's never been an epidemic of suicide that any epidemiologist has ever said to me or others that we've consulted with. So clarifying that and helping the public understand that there isn't an epidemic is really, really important. And so if you're going to put that in there, clarify that there isn't one, or just avoid putting that in there because it just doesn't exist.
Just to follow up on Dr. Franklin's comment about the pictures, I have to put a picture with every one of my stories. Welcome to our content management system and how it works. So, yes, there has to be a photo with every single story, and there's nothing worse than trying to figure out what pictures to do. I have suggested that for years, that people don't really need, I've said they don't really need a headline either. They can just use my photo and people. But if you go through, and we're very sensitive looking at this, but even if you go through divots, if you go through the Department of Defense imagery services, you can find some really just awful photos that captured with suicide there. So it's something that I think, especially reporters who are working quickly on deadline aren't necessarily thinking of the photo. We don't always think of that thing. We've seen photo editors drop off. That's a challenge. One thing that I have found is extremely easy, and I've been told is helpful, is just dropping in that paragraph about the suicide hotline, just dropping in that resources thing. Depending on the story, there's certain times where you may feel that some of the methodology, some of these other recommendations work, don't work, you have pushback, but I haven't found any case where it hurts or it takes away in any way not to just drop that paragraph at the end of the story, just to let people know that's there, that resource is there, and it's an easy contribution.
It's such a good point too, though, Leo, because we see where after there's been a lot of media coverage on a particular suicide, the numbers go up for the call center. And I know my colleagues can talk about the numbers for the Lifeline and outside the veteran space, but we actually see on the VCL the call center data, in pockets of geographic areas where the call volume will increase. And I'm pleased if it's increasing because people are at risk and they're getting help and care, and the power of the media. As a clinician, to know that the media is equally as important in this fight is just incredible to me. But I hope that the stories are not contributing to the risk in some way too. So, but I don't know if you had something, Jerry?
No, we just published a paper on the few days after Robin Williams' death, and clearly calls for help seeking increased dramatically, not just at websites of suicide prevention organizations, but also the call centers. And in addition to that, because the means chosen were described, there was an increase in that mean over the period of time that was looked at in the study. So it really does matter, I guess, is the point I wanted to reinforce from Dr. Reidenberg, that those details are picked up by people who are at risk, and we want to have everyone do their part to help us not reinforce that message. The other point I would end with is it's really important for me anyway that we recognize, and it goes to the point I was saying earlier about veterans not being broken. There are 47,000 suicide deaths in America every year. About 6,100, 200 are veterans. 40,000 are the general public. And 10 million Americans have serious thoughts of suicide every year. This is a national problem. This is not just a veteran problem. Although it is that for certain, it is a national problem that we should be mindful of so we can muster the resources to invest it in discovery like we did with HIV/AIDS years ago, like we did with motor vehicle traffic, and look at the results, accidents, and look at the results we've seen when we've made the investment commensurate with the true weight of the illness or the challenge. And I think the same thing is true with regards to suicide. We haven't made the federal investment in research that needs to be made to find the discovery that can lead to reducing suicide for the general public at large.
Can I just add something too about like one thing that came to mind was the negative campaigns that focus just on suicide. For example, the 22 a day campaigns that happened there. For a while there was a lot of campaigns going across the country about 22 veterans died by suicide, and there was push-up challenges, and there was news articles about it. And we saw the direct impact of those campaigns in our population, where we had family members coming to us where their loved one who was a veteran actually left suicide notes saying, I'm going to be one of the 22. So those kinds of negative focusing campaigns actually breed hopelessness and helplessness in those who are suffering. So shifting the message about how many are living that day, how many are surviving, hopeful messages about how to do that really can save lives. And we need to partner with you on saving lives in that manner.
I think we're at time, so I just want to thank all of our panelists for being here today and for all the great questions. I believe everyone's going to be here after the event. I know there's still more questions. We are available to have those conversations. But this is, an ongoing conversation, and we're certainly a resource for you. Maureen Iceland with the Action Alliance is here. I know there's folks from the VA, as well as all the organizations up here. If you have questions or you're wanting to be in contact with other national suicide prevention experts, we're happy to do that. So thank you, everyone, for coming today, and we'll be in touch.
Thank you, Colleen. Thank you, guys.
I knew another question would take us
Yes,
way over.
that was great.